Dear colleagues, dear friends from the Eastern country, neighbor, I'm very happy to be here. This is actually a presentation that was scheduled for my wife, a vascular anesthesiologist, but for family reasons she could not come, and as a simple vascular surgeon I tried to keep this very simple. We've been working together, for example, with this local anesthesia for carotid endarterectomy. Back in 1954, when the first carotid operation was performed, local anesthesia was the method of choice. And also in our hospital back in 1984, this paper was published by procedures in our carotid surgery. But it was abandoned, and for a couple of decades, and back in 2005 we went with Anders Albeck to Malmö to catch up again with local anesthesia enthusiasts, because that is the standard monitoring and the best monitoring device we have available. We have others like TCD, near-infrared spectroscopy, somatary sensory evoked potential, stump pressure, or routine shunting, but none of them are equal to local anesthesia. About the indications and science, I can be very frank and short. We have the GALA trial. We did not attend the GALA trial because we counted the figures, and in our heads it sounded like we would never reach significance, and that was the result. Because the complications luckily are very few, then we don't find a significant proportion with 3,500 patients. So actually we can state that both general anesthesia and local anesthesia are safe for the patients. There are some subgroups, but none of them are very strongly statistically significant. The recommendation is to do local anesthesia if the contralateral side is occluded, but if the center is not experienced in local anesthesia, I think it's better to do them in general anesthesia anyway, and nobody will prosecute you. About the sensitivity and specificity against local anesthesia, there are of course numbers. The figures look like this, but as stated earlier, local anesthesia should be the gold standard of brain monitoring, because I mean, if we're awake, we know we are alive. What we are trying to perform is a good operating atmosphere for the surgeon, and a nice calm atmosphere for the patient, and that should be pain-free. It's not always pain-free, and that is why the anesthesia team has to be experienced to give more general anesthesia, maybe some more sedation, maybe painkillers, and maybe the surgeon has to put in some more local anesthesia. The nerves are probably familiar with, for you, the most important ones, and you can approach this this area with two different methods, but as we see, what we are going to anesthetize is much more than we aim. We are going to anesthetize much more than only the pain away. So maybe there are some effects, but what we have seen, the effects are merely positive, like blocking the baroreflexor at this point. If you look at where to put the vascular bundle anesthesia to the neck, to the C2, C3, C4, C5, you are actually doing it very difficultly, and this kind of surgery you could perhaps do in local anesthesia, but not recommended. This is from a tumor surgical case. But mainly blocking the C3, C4 area would be enough. This is the first method that we used, that they used back in Malmö in 2005, but actually we went to Copenhagen a couple of years later, and they have a dead easy method which even a surgeon can do, and that's why we adopted that one. To have a deep injection, superficial intermediate injection, and a superficial injection means that you put 40 milligrams of Narapin to the neck, and as our formal chief of cardiac surgical anesthesia said, that if you put 40 milligrams to one neck, it doesn't matter where you put it. But actually it's not so. There are some places where you can put it and the patient will not be anesthetized. So, but this is the difficult method, to find the right routes, to put it there on palpation, to find the bone, put the superficial. You need very simple methods. This is totally inexpensive. maybe do some ultrasound for tracking the bifurcation, but and which is very easily recognizable. This is the common carotid artery. If you don't know which it is, then just put on the colors and you see the blue and red, or actually the compression test is much easier to identify the bifurcation. This is what we actually do. In ultrasound guidance, we put the needle behind the common carotid artery, as you can see, and inject about 10 to 20 milliliters of the local anesthetic, which will, if we're lucky, go into the carotid sheath, because the carotid sheath is the one that is painful during the operation. Then putting furthermore 20 mils superficially will give you the possibility to approach the carotid artery, and also maybe to the sternocleidomastoid process area, muscle area. But the important, this was the dead easy version from Copenhagen, that you just in ultrasound guidance put in some local anesthesia. So don't put on palpation to the cervical root, but only to the carotid bifurcation, then superficial. But why it was abundant back in 1990 about was that the patients were not properly sedated, they were not properly prepared, and maybe the surgeons were and the anesthesiologists were not enough prepared for movement cramps and an occasional general anesthesia when the patient does not comply with the treatment. And the surgeon should be aware of changes before they happen. So that's why we have TCD and NIRS on these patients as well, so we know ahead of the symptom development that we might need some shunting coming up. The changes usually come, actually, according to one study, the changes come at a median of 14 to 17 minutes. So the changes it's rare that they come immediately. So even when you have your carotid open, you might have to shunt during the operation. In the UK, they call this a rugby player. This patient was actually operated in a local anesthesia, but if I would operate upon him again, I would not operate on local anesthesia, because if you see a very short neck and a strong person with a high kinking, and this patient also had a high carotid artery, so the operation can be uneasy for the patient, but also uneasy for the surgeon, because in good situation the surgeon feels much safer during the operation, but in a bad situation, like I think Anders Habeck had yesterday, he was not very happy with the local anesthesia. This was a C2 level stenosis that we tried to do in local anesthesia, and it was a success that the patient is fine, but maybe it would have been clever to do it otherwise. So taking this into account, I think that would be the primary choice. Now we're taking my 7 minutes and leave some room for discussion. Thank you very much.
It's known GALA studies, when they compare general and local anesthesia in a CEA, they don't show the advantages of both methods, but we know how unpleasant feelings patients have in this operation, and even a surgeon may feel these feelings. Maybe we shouldn't try to go in a very complicated way, but just to apply general anesthesia, because according to our experience, the results are not worse, even better, and maybe there are some advantages of local anesthesia, despite the data of GALA trial.
That's exactly true, and as I tried to state, that you cannot say that either one of them would be better or worse. It's a matter of opinion. The chief surgeon in Malmö says that it's unethical to operate patients on general anesthesia, but I disagree with him. I think we should have both methods available. Our primary choice is to have them on local anesthesia to do TCD and NIRS, and with this we have reached quite low numbers of complications. The patient monitoring, the flow in the operation theater, the patients are awake much quicker. The surgeon actually has better time to do the operation quite calmly to the end when he knows that the patient is feeling well. If he only relies on some ultrasound noise or a NIRS monitoring, which we know have some problems, even though 20% is some kind of a limit for shunting, but we don't know if it works, those are all surrogate markers for brain activity. Those are not awake patient having a awake brain. So I disagree that general anesthesia would always be better. I disagree with that local anesthesia would always be better, but there are certainly situations where I would, after 2005 experience local anesthesia, which is our primary choice, I would never back to go to routine general anesthesia.
Тогда можно провокационный вопрос. Какую выбрали бы анестезию вы для себя?
Good. Local, and we have done this because I know I have a low carotid bifurcation. Definitely local. We have asked the patients, and they feel better after local than after general.
Спасибо.
If it goes well. I'm sorry, I'm not hearing the interpretation. Kolka carotid endarterectomy means that how many carotid endarterectomies, but I don't understand the question. I don't have a
The question is, сколько каротидных эндортерэктомий делается в Финляндии и какая часть из них делается под местным обезболиванием?
Okay, in Finland 740 last year, 227 in Helsinki last year, and under local anesthesia we do something like 65%. In Helsinki, in some centers they do 100% local, but I think that's not always optimal.